Fetal cardiomyopathies, evaluation and management, a low middle income country perspective. I am Dr. Arun Gopalakrishnan from Sri Siddhartha Institute for Medical Sciences and Technology in Kerala, India. So, cardiomyopathies in fetal life are an extremely unusual diagnosis and not commonly encountered in routine cardiac practice as well. That is what makes this topic interesting. It has been reported to be seen in 2 to 7% of neonatal cardiac admissions in series from Canada and the UK in neonatal life. However, the prevalence in fetal life is reportedly higher. It constitutes 8 to 11% of cardiovascular diagnosis, yet it constitutes a rare pathology. And it is associated with high intrauterine losses. In fact, 1/3 of them tend to have an adverse outcome. And unlike cardiomyopathy in newborn life or in adult life, there is only one modality of investigation, that is fetal echo. That's the key to diagnosis. Now, how do we come across these babies for evaluation? This is our experience from our center. The most common reference to us is basically maternal indication when the mother is diagnosed with diabetes, or a mother has a congenital heart disease or a cardiomyopathy, or a prior child is diagnosed with congenital heart disease, or the mother is treated for infertility. And some of the common indications from fetal side for evaluation include soft markers or an abnormal fetal cardiac screen identified by the radiologist or the gynecologist, rhythm abnormalities, and other abnormalities as listed below. Familial indications like Mendelian syndromes and paternal congenital heart disease are rare reasons for referral. So, some of the definitions for cardiomyopathies in fetal life differ compared to that is seen in postnatal life and thereafter. Fetal dilated cardiomyopathy is diagnosed by using a fractional shortening definition of less than 28% with ventricular dilatation Z-score more than +2 without thickening of the walls. And when this is associated with prominent trabeculations and deep myocardial recesses, we can diagnose fetal non-compaction. For fetal hypertrophic cardiomyopathy, again, the parameter uses increased wall thickness with a Z-score more than +2. Fetal diastolic dysfunction is extremely uncommon compared to systolic dysfunction in fetal life, but it portends a grave prognosis. And it is diagnosed by mitral inflow Doppler, abnormal mitral or tricuspid EA ratio, increase in the interventricular relaxation time, increase A-wave reversal in the venous side, biphasic flow pattern, or umbilical venous pulsation. Any two of them constitutes fetal diastolic dysfunction. Hydrops fetalis, when the baby gets bloated up in the fetus, can be mild, moderate, or severe, depending on the number of sites involved. And when it is associated with subcutaneous edema or skull edema, it is considered as severe hydrops. Now, fetal hypertrophic cardiomyopathy, when the term comes, people might think that we are going to see hypertrophic cardiomyopathy as we see in postnatal life, but that is not the common case in fetal life. The most common reason for hypertrophic phenotype is a maternal diabetes mellitus, and other syndromic lesions like Noonan, alpha thalassemia, twin transfusion syndrome, and familial hypertrophic cardiomyopathies are much rarer. So, maternal diabetes mellitus associated fetal cardiomyopathy is characterized by disproportionate hypertrophy of the interventricular septum. That is because insulin is an anabolic hormone, and fetal hyperinsulinemia leads to glycogen accumulation in the interventricular septum, and it is a marker of poor maternal diabetic control. It's usually seen in third trimester of pregnancy. Fortunately, they have a progressive regression of hypertrophy after birth, and generally it has a good prognosis, rarely associated with fetal hydrops. And this is one study from Egypt where they identified a septal thickness in fetal life more than 4.5 millimeter as a risk marker for adverse outcomes. Fetal dilated cardiomyopathy is an ominous entity. This is the largest paper on fetal dilated cardiomyopathy till date. It's from Shivashankaran et al., who was the head of department a few years ago. It was reported in 0.2% of fetal scans, and biventricular involvement is seen nearly half, and the prevalence of hydrops fetalis is quite common. And 1/3 of them have AV regurgitation as well, and 1/4 of them have endocardial fibroelastosis. So if you see what leads to fetal dilated cardiomyopathy, majority of them are related to metabolic or genetic abnormalities, and they have a poor outcome. Most of them do not survive. Infection is the next most common, and parvovirus, they also tend to have a poor outcome. But coming to the next most common, fetal anemia, most of them tend to survive, and they have an RV involvement more common. Some of the other causes, again, are more relevant to diagnose in fetal life because we can make a difference to them and they have a good outcome. renal causes and other causes have bad outcomes, unfortunately. So, in short, secondary fetal cardiomyopathies are the more treatable forms, and they are more common than primary cardiomyopathies in fetal life. And cardiac causes can be rhythm abnormalities, structural heart disease, or tumors. High output cardiac states can cause cardiomyopathies. Pathology of the heart and the thoracic cage can also alter ventricular filling. So does placental anomalies. This is a case of a 26-year-old primary who presented to us at 28 weeks of gestation with incessant tachycardia, as you can see in the fetus. And in a matter of hours, the child went into fetal hydrops. And the tachycardia was incessant with a 248 per minute cycle length, 1:1 AV relationship, and careful evaluation led to the diagnosis. There was spontaneous termination and reinitiation of the tachycardia in sinus rhythm. This is possible. It is possible to diagnose PJRD in fetal life, like we do so in postnatal life using the characteristics shown in the ECG here. So this baby was treated with transplacental antiarrhythmic therapy, and the tachycardia was terminated, and the baby had a good outcome, uncomplicated delivery, and child is now 3-year-old and asymptomatic. So some of these cardiomyopathies can be treated very well. This is another complex case, a 23-year-old gravida, a fourth gravida who had 2 children who had died earlier. This mother was referred at 29 weeks of gestation because of fetal bradycardia with bad obstetric history. And the parents underwent genotypic testing, and they were carriers of long QT2 gene, although none of the previous children had long QT syndrome. And this baby, who was referred for a bradycardia, was noted to have a tachycardia in the echo. So the baby had ventricular tachycardia, LV dysfunction, hydrops fetalis, functional pulmonary atresia, and duct-dependent circulation. So bradycardia on the one side, ventricular tachycardia on the other, normal AV conduction identified in fetal life, group beating, these are all characteristics of fetal long QT syndrome. This baby is also treated with transplacental antiarrhythmics, and the baby could be delivered, although the baby could not survive beyond the first week because of other reasons. So these are some of the structural heart diseases that lead to fetal heart failure. This is AV valve regurgitation leading to heart failure, and regurgitation of the semilunar valves, as opposed to pediatric heart failure or adult heart failure. Regurgitant lesions are more ominous than obstructive lesions in fetal life. Pressure overload conditions like biventricular outflow tract obstruction, critical obstruction of the systemic outflow tract, hypoplastic left heart syndrome developing a restriction of the foramen ovale, or premature ductal closure are rare causes of fetal heart failure. Coaptation, as described in the series by Shivashankar and Fetal, has a good prognosis if identified and treated on time. It can be identified like this when you have an ischemic narrowing, but sometimes the diagnosis may not be all that straightforward. As in this case, we have a 30-week-old fetus who was evaluated for, referred for identification because the ventricles appear hypertrophic. As you can see on the panel in the left, ventricles appear hypertrophic. We specifically look for LV or RV outflow tract obstruction. There was no LV or RV outflow tract obstruction. And the panel on the right below clearly shows that the arch is well open and patent. But this baby presented in the newborn period on day 10 of life with poor activity and had critical coarctation and duct-dependent systemic circulation. So the moral of the story is some of these cardiomyopathies, like coarctation, may evolve over a period of time, and these babies need close follow-up. And this is another treatable form of cardiomyopathy. This was a 37-week fetus who was diagnosed to have fetal hydrops with a gross tumor. And unfortunately, it was left for a spontaneous demise by the treating team, and they were waiting for the baby to die in utero. When we saw the baby, we rushed the baby to, in collaboration with our obstetrics team across the road in the Government Medical College. The baby was delivered by cesarean section and intubated before the first breath by exit treatment, that is ex utero intrapartum treatment. Pericarditis was done in operating theater, and now the baby is 6-year-old, has a cardiac fibroma, which has come down in size, and the baby is now asymptomatic. So some of these abnormalities may relate to changes that happen in structures that are essential in the fetal life, like in arterial duct. When the PDA, which is supposed to be patent in fetal life, unfortunately closes off, that is an ominous entity in fetal life and can lead to heart failure. Now, how does that happen? Especially following intake of NSAIDs, herbal teas, high dose salicylates, or mother takes dark chocolate, excessive coffee, berries, red apple, olive oil, these can precipitate such a condition, and the baby can present in fetal life with the tricuspid regurgitation, RV dysfunction, hydrocephalus, intrauterine death, oligohydramnios, persistent pulmonary hypertension in the newborn period. Unfortunately, it can be a critical condition to manage. These are the diagnostic features by which we diagnose this condition in fetal life, again, based on single imaging, that is fetal echocardiography. These are the criteria that we use. And how do we manage these babies? We have to eliminate the precipitating factor which led to the condition in the first place in the mother. And these babies will require close management in the newborn period, like we manage persistent pulmonary hypertension of the newborn. Fetal non-compaction, as we saw earlier, 2/3 of them are associated with additional structural cardiac anomalies, as described in this series by Stolberger et al. 33% of them tend to be biventricular, as unlike in postnatal life. And when they present with fetal hydrops and complete heart block, they are markers of poor survival. Autopsy series have shown that endocardial fibrosis is seen in 92% of these non-compacted babies. And sometimes they may be associated with structural heart disease like AV canal defect, double outlet right ventricle, pulmonary stenosis, or transposition. This is another ominous entity which has been described in the series of dilate phenotype in fetal life. This is one of the cases that we saw as well, where unfortunately the baby's blood vessels have extensive calcium deficit. This is because of some of the precursors, stem cells and smooth muscle cells, over a period of time undergo transition into osteoblast-like cells, and there are certain factors that affect the transition, like vitamin D, parathormone fragments, bone morphogenic protein. These are associated with poor survival, and on occasion it has been reported to be associated with intrauterine infections as well. And again, these babies are worked up with fetal echocardiography. When they present early in life, they require amniocentesis and other workup as well. Another treatable cause of cardiomyopathy in the fetal life is fetal anemia. Again, this is diagnosed by fetal echo, evaluation of the middle cerebral artery velocity. It may be non-immune or immune, and it can be treated by intrauterine blood transfusion. Now, this is how it is done. It may be done, the blood may be transfused into the umbilical vein or portal vein, or into the intraperitoneal space, as described in this paper by Vivek et al. We use O-negative leukodepleted gamma-irradiated packed cells to achieve a hematocrit of 45% or more. Familial dilated cardiomyopathy is an extremely rare condition. So when we talk about fetal cardiomyopathies, most of them are secondary cardiomyopathies. Dilated cardiomyopathy, familial inherited dilated cardiomyopathy, are extremely uncommon in fetal life. However, if they occur, they have a poor prognosis, and the recurrence rate is also quite high. So in summary, fetal cardiomyopathy is an uncommon diagnosis. Most of them are secondary cardiomyopathies, and many of them are treatable. Primary cardiomyopathies are rare in fetal life, and comprehensive fetal cardiac services with the teamwork is key to optimal outcomes. Thank you.